guys should be proud of yourselves. You're doing great so far. We're getting through that book, right? We're about a good third of the way through that textbook and surviving so far. We're get through sensation here, and all right. We don't, and really only have about, by the time you take out the days you're not here for CSM when I'm gone, and the finals week and some of the test days, you really only have about 6.5, 7 weeks of materials. We're already at end of week 3. Is this what we're at right now? So I'm getting close to halfway done. So, clinical perspectives or clinical applications of somatosensation. I'm not crazy about how your book does this. It just seems like it's all over the place on this. It's just kind of like, especially in how they talk about pain and that kind of stuff, it's still a little bit, to me, not clear. We'll try to make it a little more clear. However, there's still debate on terminology and what to call some of these things, especially when we start talking about chronic pain versus neuropathic pain, and the different textbooks will use different terminology to describe that. We'll stick with yours just so we're consistent. But starting with a couple things related to sensory testing. So you guys have been introduced to sensory testing in movement science. We're going to talk a little more detail here. These are some of the things I mentioned previously, is that if you're going to do sensory testing with somebody, you really need to do it hopefully in some quiet environment with minimal distractions, and the person has to be cognitively intact enough to understand your directions, and you have to be able to communicate with them effectively, generally verbally in some way. So it's really hard to do any somatosensation on somebody with dementia or somebody who has limited cognition or limited consciousness. I mean, you can do really gross screening like deep pain. You've seen when they've done a sternal rub on somebody who's relatively comatose, and they're trying to see if they just feel basic deep pain. They'll go and rub their sternum just to see if because basic deep pain is actually experienced at the thalamus and even in the brainstem some. So you might get a kind of primitive reaction of somebody, but that may mean their cortex is very damaged, but they may respond to just this deep sensation of pain. If you don't respond to any deep sensation of pain, that means your cortex is pretty well, and your cerebrum is not working, and even your brainstem probably has some limited function if you don't respond to any deep pain. The other one they do is the supraorbital pressure. Have you seen that at all? So there's like a spot right here. There's a nerve that exits just above your orbit here, and you push. You can kind of feel a little notch right there, and you just push super hard into that. Don't do it if you don't want to, but it almost makes you feel like your eye's going to go blind when you push on that, but it's just this little notch right there, the nerve that comes out, and you just keep pushing there really hard, and you see if the person winces or turns their head away from the pain or those kind of things. So I've never done that. I've never had, that's something the doctor does or something like that. I've never gone into a sternal rub on somebody or supraorbital pressure. Less of my brother maybe one time or something like that when we were kids, but so quiet environment is key. Patient comfortable. You don't want them freezing or too hot or uncomfortable. If somebody's sitting there in their wheelchair and they've got a sore on their bottom and they're in pain, trying to do light touch sensation is going to be harder because they're distracted and those kind of things. So as best you can, get the patient comfortable. Do a really good explanation and demonstration of what to expect with the test, how you're going to perform the test, and exactly how you want them to respond. Give them, do you want them to say yes or no, or or when they no longer feel the vibration, say now, not maybe, or I think so, or something like that. So give them specific ways to respond. Apply in a systematic fashion. I've always said you can never go wrong with working distal to proximal, especially when we're talking sensation, because it's more common to lose sensation more distally. In most cases, it's because the signal has to travel a longer distance, right, to get back to the central nervous system. So it never hurts to always start distal to proximal and work getting medial and lateral parts of the limb. Even if you don't remember exactly what dermatome you're looking at or peripheral nerve distribution, if you just get a good smattering of distal to proximal and medial to lateral representation, you're probably going to do pretty well. Comparing left and right is never a bad thing to compare left and right. Okay. Occasionally I will vary the timing, especially if I'm doing just light touch sensation. If you're just getting this habit of touching them the exact same frequency and the exact same time, they just get this habit of saying yes, 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 and you may not even touch them, and they keep saying yes. So sometimes I pause to catch them to see if they're just saying yes because they're expecting to feel the sensation, even though I haven't touched them yet. So sometimes I do that with light touch. So here are kind of the major types of sensation we test for, can screen for, at least in physical therapy. There's diagnostic testing we'll get to in a second that's more sophisticated, nerve conduction velocities and somatotopic evoked potentials. But the types of stuff we do is, first of all, is this discriminative fine touch. That's, that fine, discriminative, conscious touch, or touch localization. So that's one thing, is touch localization. That's where you would take a cotton ball and you would touch them. And first of all, I would be asking them, first of all, do you feel it? So just say yes if you feel the cotton ball. But occasionally I would stop and say, as I'm doing this and they're having their eyes closed and we're going back and forth, this little proximal, I'll say on one of those stimuli, if they say yes, I say, now point to me where exactly I touched you. Okay? That's the discriminative part of it. If they're just feeling just the sensation, that could be also carried on, that can be carried on just the dorsal columns or the anterolateral system. But it's when they can tell you exactly where you touch them, that's truly the dorsal column, medial lemniscal system. Does that make sense? So, if you've got a patient who's perfectly aware, perfectly conscious, you're not expecting them to have sensory deficits. Maybe you come in after a total hip, You're not expecting them to have sensory deficits. They don't have history of diabetes or peripheral neuropathy, but you might just go in and you ask them, how's your leg feeling? Do you feel like they're feeling about the same right now? Hopefully by then the spinal block is worn off or something like that. And if they say, yeah, great, and I might just rub their leg and just say, does this feel the same on both sides? Yep, feels the same on both sides. I'll rub from their foot up to their calf and just say, does that feel the same? Great. There's probably not a need for me to go in to get my needle out, get my tuning fork out, and do a lot of testing. They're there for an orthopedic problem. I'm expecting normal sensation. They seem to have normal sensation. They're perfectly conscious aware. They're reporting they feel the same on both legs. If people are consciously aware, they will know if they feel numb somewhere. Oftentimes they will be able to report that. Not always, but a lot of times they will. But if I walk into a room and the person has a stroke or has a history of stroke and they've got a total hip, and I'm going to make sure I do a little more careful screening of sensory pathways and those kind of things. Okay. So touch localization is one, and that's the cotton ball, and then asking them to point exactly to where you touch that cotton ball on some of the time to make sure that they're feeling that. Tactile thresholds, which we'll show you a picture of in a second. This is where you use a special Semmes-Weinstein monofilament tester that has a little, basically like a fishing line attached to it. It's a little short piece, and they're different thicknesses, and you press it onto the skin and you deform it. And we'll let you guys pass those around and play with those later. And if they can feel it when you press and it deforms, then that means they can identify that particular amount of pressure on their skin. It's a way of gradation to give a gradient to the amount of pressure you're feeling on your skin in a somewhat, measurable way, right? And so you press on this, and if they feel it, then you go to the next thicker, and you see if you can, or they go to the next thinner. If they can feel a certain thickness, you go thinner and thinner until they no longer can feel it. So the threshold is the last one that they could actually feel when you pressed on their skin, okay? Different parts of our skin and parts of our limbs have different tactile thresholds. Your fingertips and your toes and so forth have pretty low thresholds. I mean, you can use a pretty thin little monofilament on there and still feel it. Whereas your back or your thighs or your forearms, you have to have a pretty thick monofilament to feel it, because you've got these, you have less density of receptors. They're not as sensitive, the receptors that are in there. So, you have these, it takes a thicker gauge of this monofilament to feel it. And there's normal values. And it's actually, that we'll show you in the kit. It's got a little piece of paper. It shows you the key areas you're supposed to test with this kit, and it gives you normal values, and then diminished sensation, where you say that's lower, and then loss of actual protective sensation. So there's a threshold, especially for the feet, is where they mainly test this, that if they can't feel a certain thickness, if they can't feel a certain thickness of that monofilament, that means they've lost protective sensation, which is sensation that tells you whether you're damaging the bottom of your feet, whether there's a big rock in your shoe, or whether you're having a blister being developed. And if you've lost protective sensation, that means you got to be extra careful about what kind of footwear they have, and maybe they need an orthotic, and maybe they need special diabetic shoes and those kind of things. So that's often done more in diabetes clinics or if you're working with a lot of peripheral neuropathy, but it's always nice to have these kits around. The kit we have is the full kit that has like all the levels, but some people will just have in their clinic like a kit that has 3 or 4 levels that are just right around that threshold for, you know, the threshold for destruction of tissue and so forth, so protective threshold, so they can test just above and below that threshold to see where they're at, just as a screening device. So means you have a high threshold for feeling the stimulus. So yeah. So that's, you have a higher threshold in order to elicit a response. It takes a higher level of stimulus to elicit a response. That'd be a high threshold. Then the next one is 2-point discrimination. So 2-point discrimination is the one where we touch with you a little thing that has points on it that are different distances apart. And remember I said with the density of receptor fields helps determine how close you can feel 2 points because they have to fall in 2 distinct separate receptor fields. So if you have a lot of little receptor fields, there's a better chance you're going to get those 2 points to fall in 2 separate receptor fields and tell your brain, I just felt 2 points, okay? So 2-point discrimination requires an intact cortex where that sensation goes and is processed up in the cortex. Then the other ones, gravesthesia and stereoagnosis and double simultaneous stim, those are all ways of testing a specific region of your cerebral cortex that is the parietal association cortex, or also known as the cortical sensory organization area, or we call it the parietal association cortex. So gravesthesia is where we actually, and we'll play with this too, is you take somebody's hand and you draw a number or a capital letter on their hand. Their eyes are closed, and then they are telling you what number or letter you wrote on their hand. That's the ability of your. First of all, you do also have to, in order for this to work, you also have to have an intact primary sensory cortex, right? So you have to actually be able to feel your hand. So if maybe you did your light touch testing and it checks out, good. But you still think there's something not right here. They seem like they still have some difficulty with manipulating objects or using their hands correctly. I'm going to test gravesthesia or stereoagnosis. And so the light touch sensation with the cotton balls checks out, but then when I draw a number or letter on their hand, they can't figure it out. That's because the area just behind the primary somatosensory cortex is damaged. The area that says, I'm taking those sensations, basic light touch sensations, and now making them into a symbol, like a letter or a number, and that's where that's formulated in that area just behind the primary sensory cortex in that parietal association cortices or cortical sensory organization area, okay? That happens with also stereoagnosis, is where you place an object in somebody's hand, they manipulate the object and have to tell you what it is. If somebody's hand is totally numb and they can't feel just light touch or vibration, there's no point in doing stereoagnosis because they can't feel the object. But if they can feel vibration, light touch pretty well, but you still think there might be damage in the cortex that is associated with that parietal association area, then you can do that gravesthesia or stereoagnosis to check that out. Okay. The other one is called double simultaneous stimulation. This is where you take a person, so if a person has just damage, so let's say right side of my brain, just that parietal association cortices is damaged, not the primary sensory cortex, so just right side of my brain. So that means my left arm or leg may have some difficulty with gravesthesia, stereoagnosis, and this thing called double simultaneous stimulation. So what happens here is if I were to ask them to close their eyes, if I just test one limb at a time, their sensation appears pretty normal. So like I'm going back and forth between the 2 limbs, and the sensation seems pretty normal, left and right. They just have damage in that association cortices, right? Primary sensory cortices is okay. But if I were to say, now, I'm going to touch you either on your right or left hand, or I'm going to touch you with both at the same time. So what you're going to tell me is you're going to say right, left, or both, okay? And so if I start touching them, if I touch their left hand, so the damage is on my right hand, a right brain. If I touch their left hand by itself, they'll say left. I touch their right hand, right. But if I touch both at the same exact time, they will only say right. Because what happens is they're just less aware. If you stimulate both sides of their limbs and it goes to those signals to both sides of their brain, their body will preferentially select the part that's going to the left side of the brain because the right side of that parietal association cortices is damaged. So they have difficulty when you touch and stimulate both at the same time, being able to perceive those two stimuli at the exact same time. So that's another kind of, that's called double simultaneous extinction or stimulation, or extinction to double simultaneous stimulation. So they're just less aware of one side because of that association cortices, that if you touch both limbs at the same time, they'll only report the normal limb being felt. Even though when you do it individually, they feel them individually if they only have to pay attention to that one stimulus. Yeah? So they lose awareness of the one that's opposite side of the lesion. Yeah. So if it's, for the case I was talking about, it would be a right stroke or brain tumor or whatever in the parietal association cortices on the right, and the deficit would be on the left. So when I touched both hands at the same time, they would only feel the right side because the left side is okay. They would not feel the left side if I touched them both at the same time. But if I just touched, but you got to be exact. I mean, you got to touch them at the exact same time. If you go boom, boom, they'll still feel it. You got to just do at the same exact moment, touch them at the same time.
So does that mean, like, since they have damage on their right, and like, let's say you're going to test their left hand,
yep.
If you were doing like one of the other tests and you like wrote a letter or like a number, would they still be able to differentiate what it was, or not really?
Probably not. So she was saying if let's say we had this person with the right-sided brain damage, left hand is a problem, they don't have good double simultaneous ability to feel. So, and then if I did gravesthesia or stereognosis in that left hand, that would likely also be impaired. So this is just another quick way to screen it if you don't have like objects to put in the hand, or for some reason you can't do like right on their hand. Some people like have like contractures and stuff like that, and you can't even open their hand to do stuff. And so you would just touch the back of both hands at the same time. So if they've got a bad contracture or something like that. But most of the time I'm doing one of these. I don't do double simultaneous stim very often if I don't have to. Uh-huh. Possibly, yes, if it was down somewhere else. This is only because it's in the association cortices, you know, the parietal association cortex in the cortex itself. If the lesion was deeper in the white matter, then they would have, you know, probably loss of more than just their arm. It might be arm and leg, and it might be more profound, the loss. So, yeah. Okay. Conscious proprioception is the next major category. So this is purely dorsal columns, medial lemniscal system, okay, that we're testing here. The discriminative touch is also mostly dorsal column, medial lemniscal system, but we just have to remember some light touch is carried on the anterolateral system. So these ones do a better job for me of isolating dorsal column, medial lemniscal system, if I care about isolating those. The main reason I want to isolate dorsal column, medial lemniscal system is if I know there's a spinal cord injury of some type, and that the spinal cord injury is not complete, like it's maybe just impacting one part of the spinal cord. That's where you see this distinct, maybe like just the back part of the spinal cord's been damaged. People with MS sometimes have lesions just in the dorsal columns, so they'll have just loss of proprioception and conscious proprioception and so forth, and they won't have any problems with pain and temperature. Or they'll have the opposite. The lesion will just be in the front of the spinal cord on that front lateral part, and they'll have just loss of pain and temperature, but no loss of dorsal column, medial lemniscal system. If somebody's got a stroke or a brainstem or cerebrum problem, most of the time they've got a mix of stuff going on. I'm not worried about because once you get up into the brainstem and into the cerebrum, the internal capsule, the VPL, and the cortex, all modalities of sensation are together, or close to each other, okay? So once you get up there, pain and temperature, conscious proprioception, they're all together. So if you have strokes or damage, once you get into the brainstem, generally right around the pons up into the midbrain is where everything gets really close together. All the way up there, damage to there tends to cause just general loss of sensation, both conscious proprioception and pain and temperature, okay? However, if you're down lower in the spinal cord somewhere, that's where it gets more critical to really isolate the two systems, anterolateral system and dorsal column systems, which for me is actually very rare that I have to really worry about isolating these systems. But it's still good to test both modalities, just in case. It never is wrong to test those two. Okay? So conscious proprioception, we can test through joint movement. So this is where when we'll do some joint testing in the lab practice of like measuring conscious proprioception by tell me which way your finger is moving or which way your toe is moving. Is it up or down? What position is it in? So one joint movement that's called kinesthesia, joint movement. That's actually asking somebody, which way am I moving your limb as it's actually moving? Which I don't do very often because there's a lot of room for error here. If I'm moving somebody's limb, their shirt might be catching or dragging on something. The way I'm moving them, and if they may feel the movement up in the shoulder or the back or the torso, they may be able to pick up for some reason which way I'm moving that limb. Am I flexing it, extending it, not because of what the sensation in their limb. It may be very impaired, but they'll feel like the back of their wheelchair as I'm pushing their limb forward, or they'll feel their trunk being moved, and they'll be able to tell which way I'm moving it without necessarily having any proprioception in their actual elbow or wrist. So I don't do a lot of that. I usually just do a position sense test where you try to do the smallest movement you can in the smallest joint you can to see if they can pick that up first. Then you work towards larger joints because there's more room for error in the larger joints. So you start out with just doing the very distal interphalangeal joints in the feet and the toes and the fingers, and asking them, is it bent or is it straight, or is it flexed, or is it down, straight, or up? Some joints you can go 3 positions: up, middle, or down, straight, down, up. Yeah. But some joints you can't. So you just either go, is it bent or straight? Okay, so you give them 2 options, and you make sure you tell them, tell me, is it straight or bent, or is it up, down, or straight? Make sure you give them the terms that you want them to use. So we'll do that in class. But there's still room for error in that. When you're moving somebody's limb, and if you don't take care to get your fingers in the right spot, and you put them on top of the finger versus on the sides, there's just things that can go wrong with that. So, and it's hard to really get a gradation of how bad it really is. It's either there or it's not, typically. You're not really sure exactly how bad it is. If they don't feel it, that's pretty bad. You already know they're really bad. If they can't feel joint movement or tell you what position, that's bad. That means they have pretty profound deficits, because that's a sensation we preserve pretty well. Proprioception is pretty well preserved, and you shouldn't have to move a finger or toe very much to get somebody to feel that. Okay, so if they don't feel it, that means they're pretty impaired. Now, vibration I like a little bit better because it does give you some gradation. So when you're doing the vibration or tuning fork, it stimulates similar receptors, the dorsal column, medial lemniscal system, but you can kind of count in your head how long does it take for that to go away, and you can tell left and right. This side it took 8 seconds for them before it goes away. This side, that sensation went away in 2 seconds. So there's kind of it gives you some ability to discriminate the severity of how long it takes. And I'll show you in class, there's actually a tuning fork that you can actually measure the amount of vibration that the person experiences, and there's normal values for that. So we'll show you. It's a special tuning fork, it's a little more pricey than a standard, but even a standard tuning fork can give you some pretty good information if you're consistent, you know how to use it properly. Then lastly is pain and temperature, which is our anterolateral system. Okay, spinothalamic tract. We're really not testing any kind of a slow pain with this. This is all fast pain and fast temperature. This is all A delta fibers that we're testing here. We're not testing C fibers, so that's a negative of this. What we're doing is just the fast pain. So sharp dull is one way. So you're not really causing pain, but that's the perception of sharpness is carried on the pain on the anterolateral system. That's that itch and tickle. You're not quite causing pain, but you're causing an irritating enough sensation that it's carried on that same pathway. Okay. And to be able to discriminate between a dull sensation. The dull is really testing more of your dorsal column medial meniscal system. It's the sharp part that's testing your actual anterolateral spinothalamic system. Okay. Hot and cold, so you can do hot and cold, and you actually don't need to make it super cold or super hot. We should be able to feel pretty small changes in warmth and coolness, and they have these special kits you can buy that you get these little like thermos mugs, and it's got this little cylinder that's metal that you slide down into the thermos mug, and it's got a little thermometer on the top. And there's actually, I don't remember the exact temperatures, but there's the temperatures that you try to get it. So they fill these mugs up with either some like ice water, or they fill it up with some lukewarm water, and you dip these in, and you want them at a certain like difference, so it's not too great, but it's big enough that you should be able to pick those up. And then what they do is that it's usually OT that does this more so, because they're testing like, can this poor patient feel a hot stove, or if they're getting a hot cup out of the microwave, are they going to be able to feel that well enough without burning themselves? And so they dip the cylinder in there. It's wet, so as they pull it out, they dry it off, because you don't want the wetness. The wetness will give you perception of cool. So you dry it off real quick, and then you just lay that thing on the arm or hand or wherever you're trying to test. I never have that available because those are little kits. They're kind of pricey to have just laying around. So one way I do a really quick screen, this is usually with somebody who's got a good intact cognitive system and can follow commands. I'll just take my tuning fork and touch it to their skin and ask, does that feel cool to you? I don't test the warm part, but if they can perceive that actually is cooler than what, or feels like a cool sensation. Now, if you leave it on there too long, it's going to warm up to their skin temperature. So as long as you're just touching it briefly to different locations, and I sometimes turn it over just so I don't warm up one little section of the tuning fork, that should feel a little bit cool to them. That's a real quick way to screen. Just working distal to proximal, just touching. Does that feel cool? Does that feel cool? Yep. So. And lastly, a thing I said I don't test is deep pain and pressure. Okay. Only typically in comatose patients. That's the Semmes-Weinstein monofilament. So you can see the little monofilament right there, and you press it till it bends a decent amount. So you've fully bent it, but you don't want to press it so far that you kink it, because once you kink them, then they're done. And these kits, the kit you'll have that you'll see that I'll pass around is $1,500 for the kit. And so these little things by themselves are about $40 a piece for one of these, but once you kink the little thing, it's pretty much ruined, so you got to get a new one. So the two best tests that I do for a quick screen that gives me, I think, to isolate the two systems that I can do for cheap, but doesn't require a lot of special equipment, is doing vibration in the limbs. That helps me identify proprioception, dorsal columns, and I can kind of gradate, gives me some idea of just how severe it is by how long they can feel that sensation. Then the other one is sharp dull. So just having, I always have, a bag of safety pins in the clinic if you're going to be in a clinic where you can get new ones each time, and then also a tuning fork is ideal. But like I say, I don't always do that on every patient. If there's no reason, if I don't expect any sensory deficits, and they're there for a reason other than neurologic reasons or something like that, I may just do that quick. Hey, does that feel the same on both sides? You having any numbness or tingling? But sometimes I'll be working with them and all of a sudden realize during one of our other activities that something doesn't seem right here about their sensations. So let me go get that tuning fork and recheck that, because I'm realizing maybe you don't have the sensation I thought you did. So, okay. Apply systematically. Usually the way you're going to apply your testing is based on your suspected diagnosis. Okay. If somebody comes to me with neuropathy, okay, diabetic neuropathy, idiopathic neuropathy, where I know that it tends to be a distal to proximal disease, meaning distal is worse, it tends to be symmetric, right and left, tends to be worse in the legs because those are the longer nerves, and eventually, though, it'll often affect the hands. I'm going to just work distal to proximal, but I'm worried about the entire limb. Distal to proximal, I'm not really worried about dermatomes and those kind of things because peripheral neuropathy affects all the nerves that are distal. so it doesn't matter about dermatomes. So I'm just doing distal to proximal and just getting medial and lateral, not worrying so much about dermatomes, and just trying to find where's that point on the way up that their sensation becomes normal, and then kind of knowing where that line of demarcation is. That's how I'm approaching that test. If I have somebody who has a big stroke on the left side of their brain, I'm expecting that if it's up in the cortex or the deep white matter, that the whole right side of their body could have problems with sensation because everything's together and crossed over by the time it gets up to their cortex. So now when I'm doing my testing, I'm first of all asking the patient, how do you feel on the right side of your body compared to the left? And they're saying, oh, my leg feels really numb, my arm seems okay, my face right here is a little numb. I might let them cue me in a little bit if I feel cognitively they can do that. But then I'm going to go and test, and I'm mainly going to be testing left and right sides, distal to proximal, but I'm testing the whole leg, whole arm, and face, comparing side to side. Again, I'm not worried about dermatomes. Once you're up in the cortex, dermatomes no longer matter. Everything's together up here in the cortex. So I'm just doing left and right is my main concern. Again, distal to proximal, but whole side of one body to the other. Okay? Versus if I have a spinal cord injury, if it's a complete spinal cord injury, then I'm worried about where is the level that below a certain level, they're not going to feel anything. And all I'm doing is I'm saying, okay, tell me where you can start to feel. Well, I can start to feel right in here. Okay, so I just start testing. I go, you have no feeling anywhere else. I might do a little quick check just to see if there's any sporadic sensation. Nope, no sensation below the level of the lesion. And then I'm just finding exactly where is that level at. And then, because that's going to be important for determining the actual sensory and motor level for this person, I'm just testing those dermatonal areas. This would be more dermatonal because you're talking about spinal cord segments here, and where spinal nerve roots are coming in, above or below the lesion. So if there's a complete lesion, I'm looking above or below the lesion. Stroke, it's more one side of the body versus the other. Here, I'm looking more this way, okay? And I'm just determining where's that last area of normal sensation. So the nipple line is their last area of sensation. But everything below that is gone. Everything above that is normal. Okay, and that's what I'm doing. Versus if somebody comes to me with carpal tunnel syndrome, and that's the diagnosis, and they got wrist pain, and they work on a factory line, and they're complaining of sensory loss and numbness in their hand, then I'm worried about peripheral nerve distribution. I'm just going into the hand, maybe the forearm a little bit, and I'm just testing. I may not even do left and right. I probably will, just to take a quick check, because they're working with both hands, and I want to see if they maybe got some starting loss of sensation going in the other hand they're not recognizing yet because this one's the worst hand. But I'm going to go in, I'm going to be testing medial, ulnar, and radial nerve distributions. I'm just going to be worried about that peripheral nerve distribution when I'm doing my sensory testing. Does that make sense? So a lot of it's driven by the initial diagnosis and expectation of how you approach the testing. But you can always default to, when we talked about testing distal to proximal, and we showed you those key areas like big toe, middle toe, little toe, inner and outer thigh, or thumb, middle finger, little finger, inner and outer. If you just do that with every patient, you're getting left and right, distal to proximal, and you're getting most dermatomes and most peripheral nerve distributions. If you just start out that way as a new student, new therapist, you can't screw it up too bad if you do that. It doesn't take that long to do it. So, some studies that we don't do that we might send our patient for, or the patient may come to us with, are things like nerve conduction velocity studies. So this is where they're actually testing how quickly and how intact that nerve is, how well or fast it's propagating action potentials. It only tests the largest diameter myelinated axons. So it will, when you stimulate, so what happens here is, here's somebody doing it, is here's this electrode that causes a stimulus. This is a recording electrode, and the recording electrode is actually on the thenar eminence here. And so they push a button, and it creates a stimulus. That stimulus goes down the nerve and causes the muscle to contract. But it's also stimulating in that nerve. That nerve will also has both motor and sensory nerves. So you're testing the entire nerve, but you're really only testing the big nerve, biggest axons in there and most myelinated, because they're the ones that are going to get stimulated the easiest. You're not testing C fibers here. You're testing big motor nerves and bigger like dorsal column, medial lemniscal, you know, 1As, 2s, those kind of things. And what it does is that what you do is the doctor will, first of all, they measure this distance right here from the stimulus to here. There's a distance. So let's say that's, you know, 5 centimeters. And they put that in their computer, 5 centimeters. Then they do the stimulus. And there's known values for a lot of these. For this would be testing median nerve is what you're trying to screen here, semicarpal tunnel syndrome. And they create the stimulus, and then at time, when the stimulus when he pushes the button, it times how long it takes for then this electrode to pick up that stimulus. So it's measuring the time it takes to travel 5 centimeters. And so it takes that velocity, it takes the time divided by the distance, and then you get a velocity. And that just tells you the actual nerve velocity. And there is known, for your age, they put in your age, and they put in the nerve, and the distance, and then it compares you to normative values for somebody of that age group. For that nerve, it should be about this, a little range. There's a range of nerve conduction velocity. If you're outside it too slow, it'll flag it and say, that means that probably you've got some myelin or some kind of damage to that. So you've got enough irritation that you've disrupted the myelin or damaged the axons enough that it's not quite as fast as it should be. Okay? So that's a nerve conduction velocity. The other thing is called a somatosensory evoked potential. Now, nerve conduction velocities are just testing segments of peripheral nerves out in the periphery. They can do this across the popliteal fossa. They can do it at your butt and do the sciatic nerve and see how long it takes to get there. A somatosensory evoked potential tests both the peripheral nerve and the pathway all the way in the spinal cord. Because what they do is they put electrodes on your scalp, like over the sensory strip. They'll put some electrodes up here. Or they'll put them up on your neck area, back here by your brainstem and neck area. But oftentimes it's on the scalp, okay? And what they'll do is then they'll stimulate. So if they put them on my right side of my scalp here, they'll stimulate my left foot with a sensory stimulus. And then they'll measure, they know the distance, they'll measure the distance here, and they'll see how long does it take that from the stimulus to actually register on the surface of my scalp here on my cortex. How long does it take to get there? And that's a somatosensory evoked potential. There's normal values for that. They would do this for somebody who's suspected to have more central nervous system problems, so in the actual pathway. Somebody with MS, somebody with a tumor, somebody with a stroke, somebody who's got damage in the central nervous system pathways, not just in the periphery. However, if they also have problems in the periphery, that's going to measure that too. If they've got peripheral neuropathy plus MS or plus a stroke, they may be getting a really slow signal because it's being slowed at the periphery, plus it's getting slowed in the central nervous system too. So that's an SEP, or somatosensory evoked potential. Lesions affecting the sensory system, and we've kind of already, here we go. We can kind of divide them into two major classifications, things that affect peripheral nerves or things that affect the central nervous system, okay? So peripheral nerves, as after they've already exited the spinal cord, okay? These are radiculopathy. That's going to be your most probably common thing you guys are going to see as a PT. A radiculopathy is impinging, damaging, hurting the spinal nerve root. So right when the nerve comes off of the spinal cord, there's a dorsal and ventral root that come together to form the spinal nerve. It's usually right there, right where the dorsal and ventral root come together, motor and sensory, there's the spinal nerve right there. That nerve root, that's a radiculopathy. Any damage to that causes either motor or sensory or a combination of problems. It's usually a combo because it's usually a mixed nerve. By the time those two that dorsal root and anterior root come together, right off the spinal cord, it's a now mixed nerve. Okay, it's got motor and sensory information. And so that's a radiculopathy. Diabetic neuropathy would be that distal to proximal. It's that peripheral nerves, most distal, get affected first because they don't have proper blood supply or nutrition getting to them, and so they tend to die off or die back, okay? And that's just all the nerves that are distal and work proximal. Some people with diabetic neuropathies, some people will tend to affect more of the larger myelinated nerves, so they lose a lot of proprioception first. But there are certain variants of neuropathy that will affect preferentially like the smaller unmyelinated fibers, like the C fibers. And these people don't lose their proprioception as much, but they get this really, especially early on, before it actually really totally wipes out the nerve, they get this really burning, deep burning pain sensation. And that's very hard to treat. And it's really, these people suffer a lot with that. So it's a neuropathy of primarily focusing on the smaller unmyelinated C fibers, which gives you that deep, achy, burny pain that's hard to get rid of. But some people just have the loss of proprioception, and it almost feels more of a numb, which is less painful, but it still has problems. They fall, they get wounds on their feet because they don't have good pain sensation or good proprioception. They lose that tactile threshold ability. So that's diabetic neuropathy. Idiopathic neuropathy does the same thing as diabetic neuropathy. It's just they don't know why. Some people just have neuropathy, not anything related to diabetes. Okay, so it's amazing how many people I've run into that have idiopathic neuropathy, where their just nerves don't work very well distally. Okay, and they get worse over time. It can be progressive in nature, or it can be somewhat static. Most of the time, idiopathic is progressive. It gets a little worse over the years. It may get bad enough that we got to get custom footwear. We got to put an ankle brace on them to keep their toes up, because it affects usually motor and sensory. All these tend to affect both motor and sensory. But we're focusing on sensory. And then we have all various kinds of nerve entrapments. Once you get past the nerve root, which is a radiculopathy, and once the nerve branches to its final peripheral nerve name, median, ulnar, radial, common perineal, you can entrap or damage any of those branches from trauma, from rubbing, from pressure, from overuse. And so all those fit under this thing called nerve entrapments, peripheral nerve lesions, and those are going to give you that more peripheral nerve distribution, loss of sensation. Okay? Oftentimes motor problems too, because again, these are still mixed nerves, right? And then we can have other things like shingles, varicella zoster shingles, which is a inflammation, a viral attack of a peripheral nerve. And that viral attack, what you'll see is blistering, and it'll affect a nerve distribution. Okay, so you can get it on, thoracic spine is very common, and you'll see it'll run right along a rib, because it's actually, the virus is infecting the actual axon and causing blistering of the skin because of the reaction to this virus, and it's super painful. Okay, so super painful. Fortunately, there's now a really good vaccine for it. So I forget when they want you to get the vaccine, but usually as you get older is when you're more vulnerable, especially if you've had chickenpox before. Nowadays we have the virus for both, the vaccine for chickenpox, so probably less people. It's usually like latent chickenpox virus that then rears its ugly head as you get older, because your immune system's not so good at keeping it at bay, and it shows up as this shingles and causes some pretty significant pain and dysfunction for people. Especially if it happens to your head or face and it gets in the trigeminal nerve or something like that, it can be really, and it can go in your eye and cause blindness. Okay? You have nerve innervation in your eye, it gets in that, so it can be dangerous in those cases. So that's the periphery. So peripheral problems that cause sensory loss. Now we're up in the spinal cord. Okay, so we've gotten into the spinal cord. If you have a complete transection, or so the entire spinal cord is damaged at a certain level, you will have complete loss of sensation below the level of the lesion. Okay, so if the level of the lesion is like T2, pretty much everything below will be gone. However, because there is some overlap of dermatomes, you may actually still have sensation down into T3, T4. Even though the lesion's at T2, the fact that your T1 and T2 dermatomes may overlap with your T3 and T4 dermatomes. Like I said, it's not this clean-cut thing you see in the, so just know that even though the lesion might be at T2, you still may find that they have some sensation still available a level, 1 or 2 levels below the lesion, because of overlap of higher dermatomes above that may overlap in certain areas. There is a very unique, very uncommon, but unique problem with the spinal cord called hemisection of the spinal cord. So just half of the spinal cord is damaged, so like just your right side or just your left side of your spinal cord is damaged. Most common with penetrating lesions to the spinal cord, like a stab wound that only goes through one half of the spinal cord, or a gunshot that only goes through one half of the spinal cord. Occasionally, you can have a freak fracture dislocation of the spine that obliquely involves just one side of the spinal cord, but most of the time it's a stabbing or a gunshot, or a knife, or an ice pick. Like when I was at, I worked at in Columbia, Missouri, at the University Hospital System in Columbia, Missouri, and at the rehab center there. It's a teaching level 1 trauma center, but we got to treat all the prisoners that were at the jail, and all kinds of crazy stuff that I saw there. But one of them was somebody had a shank, and went right through somebody's back with the shank and got just half the spinal cord, and had Brown-Séquard syndrome because of this. And it was interesting because I had the guy in the parallel bars doing some standing and walking, and he was assigned a guard. He was a murderer, and so he had a guard with him 24 hours a day. He was about 6'4", 6'6", massive guy, just tatted up, just really intimidating. And so the guard would have him handcuffed to those parallel bars. And so we'd go down to the end of the parallel bars, and then we'd have to turn around. We'd have to unhandcuff him, turn around, re-handcuff him back to the parallel bars. And it was just crazy. And but the guard thought, he goes, this guy's faking it, man. I know he's faking it. He's always trying to pull crap on us. And I tested him, and he had a true Brown-Séquard syndrome. I said, unless he really knows neuroanatomy well, his would be really hard to fake because it's a very unique presentation. So I'm like, I don't think he's faking it, but I get it, so but you've been duped by this guy before. So if you've got just half your spinal cord damage, yeah, you have a question? Yes, so there is what we call more anterior cord lesions and posterior cord lesions, yes. So we'll talk about posterior column lesions, but I won't go into anterior lesions too much at this point. When we get to, we'll actually do a whole 3 hours on just the spinal cord, and we'll go through all the possible types of deficits with different parts of the spinal cord being damaged. So if you have a hemisection, one side, so let's just go right side of my spinal cord is damaged. I'm going to have ipsilateral loss of proprioception. So I'm going to have right-sided loss of proprioception below the lesion. So if somebody stabs me at, let's just say T2 again, I'm going to have loss of proprioception on that same side below T2. It's because everything's coming up the dorsal columns, hasn't crossed over yet, so it's all coming up, whatever is coming up on the right side of that dorsal column is stopping at the lesion. It can't get up to my brain to register that so it'll be numb or loss of proprioception on my right side, below the level lesion. But you will have contralateral loss of pain and temperature, okay? So if you have, again, right side of T2, what happens is, remember that pain and temperature, when it comes into the spinal cord, it immediately crosses. So everything coming in the right side below the lesion crosses over and goes past the lesion. So pain and temperature, even though I have loss of proprioception on the right, pain and temperature is okay on the right because it crossed over immediately and made it past the lesion. But everything on my left that comes in below the lesion crosses over immediately and gets stopped at the lesion. So it's actually, I have loss of pain and temperature on the left side of my body below T2, but loss of proprioception on the right side below T2.
It might not relate to this, but like with people who have spinal cord lesions and then they have like those pains in their legs, what is that related to anything, or is that just their brain thinking that?
Just the brain still thinking, because you still have a part of your brain that, so your brain still has representation of your entire body. If all of a sudden, if you have an amputation or you have a complete transection of the spinal cord, you have cells up here that are still expecting to get information from that region of your body. And when they don't, sometimes they just start firing spontaneously. Even though there's nothing coming from your body, the cells in your cortex or the pathways that are remaining sometimes get stimulated. And even where the lesion is, the scarring that's taking place, and we'll get to different types of pain syndromes, will cause spontaneous signals to occur in those remaining pathways. Over time, they tend to get better because you recognize that those are no longer needed, that region of my brain, because I don't have that sensation coming in there, but you still have some sporadic phantom sensations that can happen. Yep. or they have an incomplete lesion. So not most spinal cord injuries are not totally complete. So there may be still some pathways getting passed, or that can still cause stimulation or sensation. Then the other thing, this is the motor part of it for the Brown-Sequard syndrome or hemisection of the spinal, is they have paralysis below the level of the lesion on the same side as the lesion. So we're talking a right T2 lesion here. My motor pathway is coming down, it crosses over, but it gets blocked, so that the motor signals going to the right side of my body got blocked on that lesion. So I'm going to have ipsilateral paralysis below the level of the lesion. Okay? So I'm going to have, when we talk about lesions and we talk about loss of function, sensation, and if we say it's ipsilateral versus contralateral, we're not talking about the pathway itself. We're talking about the loss of function as it relates to the lesion. Okay? So if I have that right-sided lesion on my spinal cord, I'm going to have ipsilateral loss of proprioception. So the lesion's on the right, the loss of proprioception is on the right. I'm going to have contralateral loss of pain and temperature, because pain and temperature is coming in, it's getting blocked from here, so it's contralateral to the lesion. The lesion's on the right, so my loss of pain and temperature is on the left, contralateral. And then the motor signals coming down are getting blocked here, but that's blocking the lateral cortical spinal tract going down to the right leg, or right trunk and leg. That's the same side as the lesion, so it's ipsilateral loss of motor function, paralysis on the ipsilateral to the lesion. Even though this is a contralateral pathway, the loss is ipsilateral to the lesion. So just make sure if I'm referencing lesions and where they're at and where the functional loss or sensory loss is, and I'm asking you ipsilateral or contralateral, it's about how it relates to the lesion, not whether the pathway itself is an ipsilateral or contralateral pathway. You still need to know that too, but make sure your frame of reference is correct on that. Okay? Posterior column lesions. These are lesions that involve just the back part of the spinal cord. Okay? Those are just going to cause pure proprioception loss. It's not that common. There's a few diseases. MS can cause that, where you get some lesions just in the back part of your spinal column. Syphilis, which is most people don't have syphilis these days with penicillin and all that stuff, but some people in certain third world countries and developing countries, and some people that don't get treatment, syphilis will specifically attack the back part of the spinal cord and cause proprioceptive loss, but pain and temperature's okay, strength's okay, it's just the dorsal columns are damaged and they got just pure proprioception loss. Okay? Just speculating though, what if you did have more of a, let's just think sensation, what if the lesion was more towards the front part of your spinal cord? What are you going to have selected? What are you going to lose if it's the front half of your spinal cord? More pain and temperature. Those anterior lateral systems are more towards the front, and it's going to cause bilateral loss. Just like if you impact both dorsal columns, you get bilateral loss, okay, of proprioception. If your front half of your spinal cord's damaged, you're going to have more sensory loss, okay? But you'll tend to also have some motor loss because the motor system is also anterior, but we're not the motor system yet. So just sensory standpoint, it'll be bilateral loss of pain and temperature if it's more of an anterior lesion. I'm going to draw this Brown-Sequard syndrome out real quick, then we'll take a break. So let's just make sure everybody's clear here. So we are going to draw a lesion first. Let's just do the lesion in black. So you guys are looking at it. So we're going to call it how you guys are looking at it. This will be right side on here. So it'll be your right. So I'm going to, and it works for me too. So I'm going to do a right-sided lesion here. Here's the lesion. So a bullet, a knife, whatever. Can we turn this into a knife? Went in there and stabbed the person on just that side of their body there. And draw a little hand. And this may be, we talked about like a T2 level. Okay, so we're in the kind of cervical. Here's lumbar down here. Here's cervical. We're kind of in between. All right. So here's our. Let's do one at a time. Let's do proprioception first. Okay, and we're going to do proprioception in blue, our dorsal column, meniscal system. So it comes in, so everything coming in below goes up into the dorsal columns, right? So it comes in the back part of the spinal cord, We've got our little dorsal root ganglion out here. But it's going to go up. So these are all the different nerve root levels coming in. L2, L3, L4, whatever. And they all go up and get blocked right here. So we have decreased proprioception and discriminative touch ipsilateral. So this is right side, this is right side, ipsilateral to the lesion, right? Because everything on this side, that is dorsal column, medial lemniscal, it goes right past, comes to the medulla, it crosses over in the medulla, goes up over here to that side of the brain, but that doesn't matter. But this is where, this is okay over here. So the dorsal columns are just fine on that side. So we have ipsilateral loss of proprioception. And then let's do pain and temperature. We'll do that in red. So if it's coming in from this side, pain and temperature, it comes over to the spinal cord, but it crosses over and goes up through the medulla and over here. So in this case, everything below the lesion crosses over and makes it past the lesion. So in this case, it's okay on the same side of the lesion. But it's now this part over here that comes up, crosses over, and now all that gets blocked. Everything below the level of lesion gets blocked there. So this is decreased pain and temp. This is the right side is where the lesion is, but this is the left side of the body that gets impacted. So it's contralateral loss of pain and temperature. But these guys over here all make it past. They cross over and they make it past the lesion, so that's why that side's okay. And then lastly, if we talk motor just really quickly, so we have motor pathways coming from here, they cross over and they get blocked here, but that's the motor pathways that are going to the muscles on muscles, whatever, on the same side, right side, ipsilateral loss of motor function because of damage to this lateral cortical spinal tract, motor tract, going to that same side. Got it? Good. All right, break time. Unless you have any quick questions. Yes, real quick.
I don't know, this might be a weird question or just dumb, but can you still have Brown-Sequard syndrome if you get, like, if he were to get stabbed in like the lumbar region, like lower?
If it was, you could have Brown-Sequard syndrome, but only two. If it was between L1 and L2, you would not have Brown-Sequard syndrome if it was below that. You would go actually probably damage nerves after they've already, if you're below the tip of the spinal cord, so that's a good question, then you're into just the peripheral nerves. And you would have a Cauda equina syndrome, which would just damage, if you stab somebody there and it goes in that one side, you would just be cutting nerve roots. And you could have loss of sensation and motor function, but it'd all be on that one side of the body. Anything below that, it's not really the level, but any nerve roots that were damaged when that knife went in, it would typically be more on that one side, and it would be complete loss of all sensory modalities and all motor function because you totally damaged the final common pathway, and they would have flaccid paralysis and total loss of all modalities of sensation all on that one side. Does that make sense?
Yeah.
Okay. That'd be a Cauda equina syndrome. So, all right, come back in 7 to 10 minutes. Okay. So we're talking about damage or lesions that cause sensory loss. We started out in the periphery, right? We started out with things like peripheral neuropathy, radiculopathy, peripheral nerve like distributions, carpal tunnel. So we talked about that. Then we moved into the spinal cord because we're moving up the chain here. So we're in the pathways here now. We're in the spinal cord. We talked about Brown's cord, posterior column, anterior cord, transection. Now we're going to move up into the brainstem. Okay, so these sensory pathways are going up to the brainstem. At this point, this is really what you need to know about the brainstem. Brainstem is more complicated because stuff crosses over there, and also pathways start out kind of apart from each other, then they all come together. So it gets messy, but right now, this is the general rule you want to remember with brainstem lesions. And then when we get to the brainstem, when we get to regional anatomy, we go through every cross section, we'll talk about very common types of lesions that happen in the brainstem and draw them out and show exactly why you see these very unique presentations of motor, sensory, autonomic dysfunction in the brainstem. But right now, just know that if you have a brainstem lesion, if somebody comes to you and they say, the left side of my face is numb and the right side of my body is numb, or there's some sensory deficit in the left side of their face and the right side of their body, the only place the lesion can be is in the brainstem. That's the only place that you can cause the left side of your face and the right side, or the opposite side of your body, okay, to have problems at the same time. That's just a very indicative symptom that they have a brainstem lesion. We're not even going to go about where exactly in the brainstem that is yet, because usually there's other signs or symptoms that will then tell you, is it in the medulla, pons, or midbrain, okay? But just know that you will typically have, and if the lesion, so in a brainstem, if the person says my left side of my face is numb, the right side of my body's numb, you know it's a brainstem lesion, and you know it's in the left side of the brainstem, because it's always the same side as the face. It's ipsilateral loss of face, contralateral loss of body. Okay? That's what I mainly want you to get out of the brainstem lesions. It's because you have the trigeminal nerve coming in right there at the pons, and you may damage, if you have let's say I have a left-sided lesion in my brainstem, it may impact those initial sensory information coming in on that same side from that trigeminal nerve, but all the body stuff is crossed over in the low medulla and gets stopped up in that pontine lesion. And so that's why I have contralateral loss of body, arm and leg, but ipsilateral loss of face. Ipsilateral and contralateral relative to the location of the lesion. So the lesion's on the left side of the face has got problems with sensation, right side of the body's got problems with sensation. So that's what I want you to get out of that. I'm not even going to draw it out, because right now that's all you need to be worried about right now. I'm not even going to draw this out. We're just going to keep moving forward. So that's the brainstem for right now. That's all you got to know. Then now we're up in the cerebrum. So this is where we come out of the midbrain. We go to the thalamus. That's the first stop in the cerebrum. Then it goes through the internal capsule, which I don't have on here, and then up to the somatosensory cortex and the parietal association cortices. So let's talk about thalamic lesions. If you have a distinct lesion in the thalamus itself, you will typically have decreased or lost sensation from the contralateral body and face, okay? I say or face because if it's truly in just the VPM, it'll just be face. If it's truly in just the VPL, it'll just be the body. But most lesions get a little bit of both. They get VPM, VPL. If you've got a thalamic lesion, there are specific vascular supply. There's a vascular territory or blood vessels that go deep into the thalamic region. So you will see occasionally patients with thalamic strokes. And if you have a thalamic stroke, you will often have sensory loss, usually both some face and body, contralateral to the lesion, because everything's by the time you get to the thalamus, everything's crossed over. All your sensory inputs have crossed over to the opposite side, right? Because either they crossed over in the spinal cord if they're pain and temperature, or they crossed over in the medulla if it was proprioception, or with the face they've crossed over. They usually go down a little bit before they cross over, but they've also crossed over. So by the time you get at the thalamus, all your face, body are together, and they're all from the opposite side. And so you get ipsilateral loss, contralateral loss of generally face and body. So it's just kind of like having a cortex lesion, but a thalamic lesion will cause that. occasionally you get a lesion that's not in the VPL or VPM, but it's another location like in the intralaminar nuclei of the thalamus that will cause this weird syndrome called thalamic pain syndrome, where these people get pain in the entire side of their body. Instead of loss of sensation, they actually experience this like phantom pain throughout the entire side of their body. It's because of a malfunction in that processing of sensory information in the thalamus that gives you this just sensation of pain. That's called thalamic pain syndrome, occasionally severe pain in the entire half of their body. Now we're going to get up into the somatosensory cortex, so the primary sensory cortex, that homunculus region, right on that postcentral gyrus, what we're talking about here, okay? If you have loss of that postcentral gyrus damage somewhere in there, okay? This is the loss that you'll have. Contralateral loss, because remember, everything's crossed over by the time it gets to that thalamus and also to the cortex, right? So you have opposite side of your body and face can be lost. You can have loss of discriminative touch. People don't, feels kind of like a block of wood, feels kind of numb. I don't know exactly where you're touching me. You know, I can't figure that out. That's discriminative touch loss. Conscious proprioception, so the ability to like tell where your foot, your fingers, toes are in space, and vibration, okay, can be lost there. Well, I take that back. Vibration is actually preserved at the cortex region, so hang on a sec, sorry. So this movement, kinesthesia and proprioception, where you're moving the limb, are lost, but vibration is actually can be somewhat preserved. It can be lower. It often will be decreased, but you may still have some preservation of vibration if it's just the cortex that's involved, that primary somatosensory area. You will have loss of two-point discrimination, localization of touch, which is the same as discriminative touch. That's really the same thing. However, slow aching pain is preserved. Deep aching pain is preserved. Vibration is partially preserved because you will actually feel, and the reason why slow aching pain is preserved is because you will actually have conscious awareness of those at the thalamic level. So the thalamus, you can get some conscious awareness of vibration and deep pain as long as the thalamus is intact, even if the cortex is damaged. Okay? That's only negative about testing vibration, although it will be usually diminished still, as that somebody will still be able to feel vibration. If they truly have a stroke that just involves that primary sensory cortices or primary postcentral gyrus area, they may still have the ability to feel some deep pain and vibration just at the thalamic level that they are still consciously aware of. If the damage involves just behind that primary sensory area, that postcentral gyrus, back in the parietal lobe, in the parietal association cortices, also known as the cortical sensory organization area. So parietal association cortex or / cortical sensory organization area. This is where you form that picture. You take all the sensory experiences you're having and you form the mental picture of whatever you're holding in your hand. That's stereoagnosis. The lack of it, the inability to tell what's in your hand and manipulate and feel what that object is called astereoagnosis. Astereo, lack of. Agraphia, gravesthesia is the ability to tell if you've got, feel somebody write or know what symbol they're writing, number, letter they're writing. The lack of it is called agraphia. Another thing that happens with people that have lesions that are just in that parietal association cortices is this what we call sensory inattention. That's where they have trouble with that double simultaneous extinction. Is they just don't, they lack awareness of that side of their body. If I have a right-sided lesion, I'll have lack of awareness. I might be able to pick it up if I pay attention to it, but if anything distracts me or I'm getting double simultaneous, I can't attend to that stimulus very well. And so that's called, that general term is called anosognosia. That's a lack of awareness of your body, okay? Anosognosia, or inattention, sensory inattention to that side of your body is the term anosognosia. Sensory inattention or neglect. You'll hear people will call patients has severe neglect. And that severe neglect can include both lack of awareness of like the entire room and the world on that side, because they also maybe have some visual deficits, but there's also often sensory deficits too, where they don't attend to that side of their body very well because of that association area that's supposed to integrate all that information coming in isn't working very well. This is one way. Double simultaneous extinction would tell you that they do have some anosognosia. That'd be a way of, that's the term to call neglect. And it's usually a constellation. When we say somebody has anosognosia, it's usually a combination of they have some sensory inattention, so they don't do well with double simultaneous, or they fail the double simultaneous extinction test. But they also usually have some visual deficits when I test peripheral vision. They may have trouble even looking past midline to that side. Because there's a part of your brain that makes up or references your visual space and three-dimensionality of your world. So it's not only the physical loss of sensation, but it's a loss of awareness of this three-dimensionality of your world on that side too. It's usually a combination, but we're just talking about the sensory part right now. Still contralateral to the lesion. Yep, all of it's contralateral to the lesion. So just real quick, this is primary somatosensory area. Then this region right back in here is kind of called the cortical sensory organization, or the parietal association cortices, is that whole area right back there. So one of the main arteries, stroke is always going to be your most common cause of neurologic problems. Just a lot of people have strokes. The same reason people have heart attacks. It's a vascular disease. So people that have heart attacks also have strokes, and people just have bad vessels. But the most common artery that is involved with a stroke is called the middle cerebral artery. The middle cerebral artery actually comes out. Here's the lateral sylvian fissure. The middle cerebral artery comes out of the lateral sylvian fissure and branches out and supplies, generally, this region of your brain. And it has distinct branches, M1, M2, M3. They actually just, and one of those branches may get blocked. So if it blocks just this branch right here, boom, I've just eliminated blood supply to that primary somatosensory area. So I'm going to have that very distinct loss, contralateral loss of pain temperature, proprioception on the opposite side of my body. However, if the blockage occurs back here and wipes out these guys, then I'm going to have more of that cortical sensory integration problem, the agraphia, anosognosia, double simultaneous touch is a problem, astereognosis. So you can have individual branches of that middle cerebral artery that will give you these very distinct sensory syndromes. It could also block the motor pathway, but it's actually more common to have the whole darn thing get blocked off. Maybe I wouldn't say it's more common, but it is very common that you block the middle cerebral artery before it starts to do all that branching, and then you basically get a big old stroke that involves a big region of your cortex, both motor and sensory, both primary sensory and cortical sensory to an extent, maybe not as bad, but also motor. So, and generally it's more, and this stroke happens here, so it tends to affect more face and arm than it does leg, because leg's up over the other side. Okay, that's more of an anterior cerebral artery problem. Middle cerebral artery problem, they'll have the same side of their face and mainly their arm that are impacted motor sensory wise, and less the leg. Okay. The other thing I just want to talk about that should be in here, so between the thalamus and it going to the cortex, it travels through white matter called the internal capsule. So the thing you need to know about the internal capsule, it's like the same as if you have a somatosensory cortex lesion. The internal capsule, everything gets really close together. It gets all squeezed down this little area of white matter in the near the basal ganglia. But so if you have a lesion, you can actually have a fairly small lesion in the internal capsule that can actually wipe out like your whole one side of your body, because all your arm, leg, everything is really close together. When you actually get to the cortex, it fans out and it goes to different regions. So even a fairly large lesion in the cortex, like I just showed you, a large middle cerebral artery lesion may only affect more of the arm and face for sensation. But if the lesion is a deep, small vessel that hits just the right part of the internal capsule, I can wipe out the whole face, arm, and leg because they're really close to each other in the internal capsule. And that's called a deep white matter lesion, okay, if it infects the internal capsule. Once it starts to spread out to the cortex, you have to have a bigger and bigger lesion to actually get arm, leg, face. But down in the internal capsule, it can be a pretty small lesion. So internal capsule lesions can be the worst because the amount of effect can be disproportionate to the size of the lesion. A small lesion could do a lot of damage if you're down where everything's right next to each other. When you get out to the cortex, it takes bigger lesions to affect more. But then when you have these big lesions, you have other problems too. You have swelling, and you have other things that can lead to death. And if you have a big bleed or a big artery impacted, it can just lead to other problems. Okay? We're going to go through the pain stuff fairly quickly here. So clinical perspectives on pain. It's important. This is really important stuff. You'll get reinforcement, I think, this in ortho. But a lot of your patients that you're seeing have pain. Whether you're seeing them for a neurologic problem, most of my stroke patients, most of my Parkinson's patients have bad hips, bad knees, have pain of some type in addition to whatever neurologic thing I'm working with. Of course, if you're in orthopedic world, your pain may be the primary reason you're seeing a lot of these people for. So specific types of pain, the sensation of pain. Pain from injured joints and muscles. So if you actually just injure a joint, muscle, that's a pretty impressive injury right there. You are going to affect immediately both A delta, you're going to affect, A delta and C fibers, okay? So you're going to get both fast pain and slow pain. The fast pain is going to happen immediately, boom, ow, and then you're going to get that achy, ischemic, burning, achy pain afterwards, okay? C fibers, those slow pain pathways, are especially sensitive to ischemia. So if you actually impair blood supply down to whatever tissue, that's going to cause that really deep aching pain. So like, have you heard of like compartment syndrome? Somebody gets like I have a fascial compartment syndrome where they get pressure built up in a muscle and it causes ischemia because blood can't get in there now because there's too much pressure. They'll get this really burning, deep, achy pain in there. You know, some people have it upon like when they're doing like running and they have like exercise-induced ischemia because of a compartment syndrome. But anytime you have ischemia, and that's why like, heart attacks cause this deep aching pain that sometimes it's hard to localize because it's affecting C fibers and it's hard to say it hurts right here. It's like this whole region hurts, or this all the way down my arm because it's causing ischemic C fiber stimulation. Okay, and if you do damage like this where you're ripping through and tearing lots of cells, they're spilling out their contents, and especially all of our cells have these chemicals in them that can cause inflammation to the cells around them. You know, bradykinin, histamine, all these things can cause signals to the cells that, hey, there's major trauma going on around me, and it'll sensitize the free nerve endings in that area to be even more receptive to getting stimulated, lower their threshold so that you blow on it and it hurts. You know, you look at it, it hurts because you sensitize those free nerve endings with these chemicals and that can cause pain themselves or just give them a lower threshold so that you barely touch it. But it's all protective. It's saying you have major trauma that just happened. Do not move this limb. Do not let somebody touch it. Keep it out of harm's way. That's part of the inflammatory process is protection. Okay. There's the concept of referred pain. That's pain perceived as coming from a site different from the actual place the damage is happening. Okay. Probably the most common is radiculopathy. So somebody says, man, my leg hurts or my foot hurts, and there's nothing going on with their foot. It's in their back. The L5, S1, whatever nerve root is being pushed on. It's getting ischemic, causing pain, but they're feeling it in their foot. But the actual damage to the tissue it's referred. It's referred pain to the area, the dermatonal area that's associated with that nerve, but they're not having damage to that tissue. Okay. Referred pain can come from visceral structures too. So you can have referred pain from your heart, from your kidneys, because they're entering in the same spinal nerve root level as the certain region represented by a dermatonal area in your body, and there's some crosstalk that happens between those. When they're both coming in that same part of the dorsal horn, your system can get a little confused. You're getting these powerful signals of of damage or pain from a kidney, but it's entering in the thoracic level that's similar to this same region of a dermatonal area represented on your skin, so you feel the pain also in that region, okay? Referred pain, that's the visceral structures. Sometimes myofascial trigger points. People have trigger points where if you push, usually it takes you having to push on it, you stimulate the trigger point and it causes pain in another location, usually within that same dermatome or that area that's represented, wherever the fascia is running. And there are some commonly identified trigger point referral patterns and common places we get trigger points in muscles or in fascia that can, you can go in and you do that with fibromyalgia when you're testing, and you can see, do they have these certain trigger points and are they referring to certain regions within their body? This is just showing you, so for example, these are all C fibers here, but C fibers, axons, they're all coming in this case, in this thoracic level. It might be whatever, T6, I don't know. Well, this would probably be more that's outside of the arm. That might be more actually, T1, C8, T1, whatever. But anyway, so these are pain fibers from the heart that are let's say you're having ischemia right here in your heart. You have free nerve endings near your heart that register pain. Those are coming in, and they're coming in the back part of the spinal cord. Their cell bodies are in the dorsal root ganglia, but you also have C fibers, pain fibers coming from this dermatonal region of your body that's coming in that same. And because these are all coming in and delivering their information in the same region, the dorsal horn, you might get a little crosstalk, and you might have that referred pain where you perceive the pain coming from that region of your body. So you can see some of the identified typical areas or dermatonal or skin areas where somebody would say pain might be, they might feel pain here that's referred from a visceral structure, an organ system. And this is what you're learning in medical diagnostics. I don't know if you guys have talked about this yet, referred pain, but this will help you with that. Another type of pain, not different from referred pain, is what we call chronic nociceptive pain. So chronic nociceptive pain. This is chronic pain due to continual irritation, damage to peripheral nociceptors. So this is like you're having ongoing injury, irritation, damage to peripheral nociceptors. As long as you keep damaging them and there's keeping irritation, you're going to have chronic pain that's associated with the actual tissue damage that's occurring. Okay? So if somebody's got a tumor and that tumor is in a region and it's continuing to grow and it's still there, it's causing pressure, damage, and destroying tissue in that area, this patient's going to have chronic nociceptive pain that's driven by the actual nociceptors, which are free nerve endings in that area, getting continual stimulation. Okay? Versus neuropathic pain. Neuropathic pain is produced by a problem or misfiring of the nervous system independent of stimulation of actual nociceptors. So let's say somebody has a gangrenous limb and they've got a wound and it's destroying tissue. The person's having pain. They've had it there for months, and they go in and they amputate. So they originally had this chronic nociceptive pain because of continued tissue destruction. They amputate the limb. The tissue destruction's gone. And let's say the initial surgical problem is healed and they should be feeling fine. But what's left, they still have pain. They're still saying they feel pain oftentimes in the limb that's not there, which is a form of phantom pain. But a phantom pain is a form of neuropathic pain. But now the nervous system, the memory or trace of that original pain is still there. It's still expecting to feel information coming from those nociceptors. Even though you've removed it, your nervous system has remodeled itself to expect and to sensitize or strengthen that pain pathway to the point it doesn't even require stimulation. It just fires itself because it's been fired for so long. It just continues to fire itself. So that's a form of, that's an abnormal, problematic type of pain that is a problem with that a pain matrix malfunction, one aspect of this pain matrix malfunction. So neuropathic pain, we could talk about it happening somewhat in the periphery, in the central, and the pain matrix malfunction. So neuropathic pain is you have an injury to a peripheral sensory nerve, but the injury happens, but then it's no longer supposed to cause a problem. The damage, the stimulus has been removed, but some people will have some leftover symptoms. If it's coming from a purely peripheral nerve that's still just kind of highly sensitized or causing these abnormal sensations, these are the types of terms they'll use to describe that. So if you hear of somebody having a paresthesia, okay, that means a painless abnormal sensation. So you know when your leg falls asleep and you wake up and it's tingling and it's like it's not truly painful, but it's still irritating and it's like abnormal and it's kind of just off-putting. That's a paresthesia. It's like there's some weird sensation in my leg. It's not necessarily painful, but it's somewhat obnoxious. I don't like it, but it's not really painful. That's a paresthesia. And so that's like you sat there at your desk. Your ulnar nerve got compressed. But then you release it, so there's no more damage being done. You're not stimulating any more receptors or anything, but you caused a little bit of ischemia in that nerve, and it's going to take a little while for that blood supply to get there and actually make sure that the myelin stays healthy and that the tissue and that the nerve works effectively. But during that time, you might get these abnormal paresthesias. If you only did it for a short time and just got a little bit of ischemia, you'll get some paresthesias. A dysesthesia is even more unpleasant than a paresthesia. So a paresthesia is truly, it's like kind of like, it's there, I don't like it. But a dysesthesia, you're like, yeah, this is a little more abnormal and a little more unpleasant in sensation. So don't ask me exactly, but just know that a dysesthesia is like a gradation worse than a paresthesia. But some books don't do a great job of differentiating what a dysesthesia. I could almost use these interchangeably. That tingling sensation could also be a dysesthesia, but it's probably, if it's not really causing, I'm not like going, wow, if I'm just going, that's a weird little tingling I got going on there, that's more of a paresthesia. But if I'm like, ooh, there's that time, sometimes you get it where you're like, whoa, you feel like it's going to get really painful and you're almost worried about it. It's like, wow, and that's more of a dysesthesia. So. Then there's a term called allodynia. Allodynia is when you have pain from a stimulus that should not be painful. So that's where somebody, like, they've hurt their hand, they've hurt their whatever, and they have so much inflammation that you go, oh my God, or you just barely, like you pull the sheet and the sheet rubs on their hand and they go through the roof. That's allodynia. That shouldn't hurt. It shouldn't hurt to have a sheet rubbed on you. It shouldn't hurt to blow on it, but you're so inflamed and the pain is so acute that you, just a typical, or just moving the limb, that causes pain. That's a form of allodynia. And then this is another one that's just like, I'm not sure your book does a great job of this. This thing called secondary hyperalgia. So allodynia is truly like, this stimulus should not be painful whatsoever. Blowing on it, just lightly touching it. Secondary hyperalgia is when you push on something or you do something to the tissue that should be slightly painful, but they have this extreme reaction, becomes really painful. So, but typically somebody who has secondary hyperalgia will also have allodynia. So this is this fine gradation, like the difference between paresthesia and dysesthesia is kind of like the difference between allodynia and secondary hyperalgia. I'm just throwing those terms out though, so if you hear them in the clinic, you read about them, I will not try to confuse you with these in like a matching section or something like that, or I'm not going to try to confuse you with those. But just, you may hear those terms thrown around somewhat loosely or interchangeably in the clinical setting, but this is how your book sort of describes them, and I'm still not clear what exactly they mean. The central problems, so you can have, that's the periphery. So these are usually associated with some kind of a peripheral nerve or peripheral disorder of the nervous system or the nerve, okay? Then we have central problems that cause neuropathic pain. So central neuropathic pain problems, this is where typically neurons in the CNS are normally stimulated by periphery become abnormally active. So this is where the central pathway, the sensory pathway that's carrying sensory information becomes abnormally overactive, okay? And this, so what happens is, for example, like I mentioned the phantom limb syndrome. So you've got this person who's had some pain for months, years. They've had this darn wound they've been dealing with for years and years, and it's caused lots of pain. And you develop and you strengthen this really strong pain pathway from that limb up to the cortex. You go in, you have the amputation done. It's gone. The tissue destruction is gone. The limb is healed. You shouldn't have any pain anymore. But now you've got this really strong pain pathway that normally is mediated by at least some normal sensation of tissue destruction coming in. But now you've cut it off from all sensory information coming from that limb, and it goes haywire. It goes wonker. It just like doesn't know how to react. So the only way it reacts is just by sending signals. You know, because I'm supposed to send signals about pain. I've got this nice strong, I developed extra connections, I developed extra receptors, I developed more synaptic vesicles so I could dump more neurotransmitter in there. I'm just going to let it happen. And it's kind of like the unrestricted. It's like kind of free to do what it wants, and it goes haywire. And they have this, like, oftentimes worse pain, this phantom pain. They still feel like that limb is injured and hurts, and sometimes even hurts more than it did when they actually had normal nociceptive pain coming up through that. But now it's like it doesn't know how to act, and it's kind of this is a dysfunction. It's called pronocioception. It actually increases your sensitivity to pain because of the strong pathways you develop. And you get this spontaneous activity, and the sensitivity is prolonged after discharge. You even get expansion of receptive fields in your brain because you've had this pain for so long from a certain region, like the part of your brain that processes information about your foot. It'll actually take over other regions close by because it's predominant. It's like getting so much sensory stimulus, it's being used, so it grows. And it takes a while for that to retract, and it usually requires some purposeful use of the limb in non-painful ways and doing this graded exposure to your patient of new movement, weight bearing, to get normal sensory experiences that aren't driven by this abnormal, overly active pain pathway. Does that make sense? So it's really hard to deal with. It's really hard to fix. They use like mirror therapy now to do that. So what you do is, if somebody's got an amputation or even pain, they'll put a mirror between the legs so they don't see their right side, which may be amputated, but they see their left leg, and they visually look and they see a mirror image that looks like their right leg. And so what they'll do is they'll have you do progressive exercises with your left leg, and by you actually visualizing and seeing your left leg, which you think is your right leg, even though you have an amputation, you think it's moving. So they'll have you do ankle circles, they'll have you do knee extensions, they'll have you do like all these coordination exercises, they'll have you do weight bearing and like little leg presses, like with a mirror between you, and eventually your brain, because your vision is telling you that's your right leg, you can trick your brain to say, hey, I'm moving that limb and I'm not having as much pain. And that starts to normalize that pathway that was overactive and downregulate it and make it say, oh, this is how I'm supposed to respond to normal. It's really crazy how you can trick the brain that way. Oops. So that's central. And then pain matrix malfunction. This involves both like central and peripheral problems together. If you hear the term reflex sympathetic dystrophy, which is RSD, reflex sympathetic dystrophy, that's the old term we used to call this. The new term is called complex regional pain syndrome, okay? Older terms than even reflex sympathetic dystrophy is called causalgia, Sudeck's atrophy. All these are somewhat interchangeable terms. If it just happens in the shoulder and hand, this complex regional pain syndrome, they call it shoulder-hand syndrome, but it's really just a form of complex regional pain syndrome. So I want you to know complex regional pain syndrome, but I also want you to know if you go in the clinic, your therapist or your CI might say they have shoulder-hand syndrome, or they have reflex sympathetic dystrophy, or they have Sudeck's, or they have causalgia. You may hear those terms. You may hear a physician write those terms. They're really all talking about complex regional pain syndrome. And usually you'll get your complex regional pain syndrome in either an upper limb or a lower limb, is the most common. So somebody who has what you think should be a routine ACL surgery, all of a sudden they start getting this massive pain out of proportion to what you'd expect. Their limb starts swelling. You can hardly look at it, move it, touch it. They get this redness. Their skin gets dry and lacks sweat. And that's a malfunction of both the central processing of pain and the peripheral response to pain. It involves sometimes the sympathetic nervous system. So our sympathetic nervous system drives vasodilation, constriction, also drives sweat responses and sebaceous gland release. And so what will happen is they'll get this malfunction of the central processing. It'll seem way too painful to what should be painful. Normally in somebody recovering from surgery has a pretty nice response, and you can start to move the limb, and it should get better over time. But they all of a sudden, it's just things go haywire. Their system gets out of whack. And then it causes these distal problems where they get the autonomic nervous system going in this protective mode, and they get this vasodilation, the limb swells up, but then they also get lack of sweat and lack of normal glandular sebaceous release, so that gets dry, and they get this flaky red skin, and then the limb gets super painful, hard to move because now it's swollen, and it's a cycle that gets started, and you're trying to break that cycle. And so it's really hard to break from some people. It might involve a combination of psychological, behavioral modifications, but also doing progressive movement of the limb in non-painful ways that's very systematic and progressive in nature, even using some of the mirror therapy, doing progressive loading. They actually have these things where you can actually take, for shoulder hand syndrome, it's called the shoulder jack, and they've got this device that you actually gives you a readout of how much pressure you're putting through the limb. And they'll send you home with this, or they'll use it in therapy, and you actually have the person who's got this swollen, irritated arm, maybe they broke their hand 3 years ago, but it never quite got healed right. Then they got the shoulder hand syndrome, but they'll have you do progressive loading. Like they'll have you stand there or sit there and load through the limb, and then you can read out, I'm putting 20 pounds of force through this, and they'll say, I want you to go up every week by 3 pounds of force. And so I want you to do 150 repetitions a day, and then you can actually measure how many reps and how much force you put through, and you do this very progressive. And if you hit a point where you're having trouble, you stay there, but you're often doing other things like combining that with visualization, relaxation. You might be using modalities. You might be doing active motion too, that tries to do active motion that doesn't stimulate the pain response or doesn't make it any worse, but you try to show how to use this limb now in functional ways. They may be taking some medication, combination of antidepressants and stuff to help them sleep because of the sleep. So it's this really, or they may be getting some injections. They do some of these blocking injections where they'll inject, like if it's a shoulder hand syndrome, they'll inject the stellate ganglion, which processes and affects the sympathetic nervous system into the arm. And they try to block the sympathetic nervous system that's overactive. So it's a combination of lots of things, and it all is a crapshoot whether it's going to work or not. It's a really tough. That's your worst nightmare in physical therapy, is when your patient gets this or walks through your door with this, and it's hard to predict who's going to get it. It's could be a genetic component or something that makes people just predisposed to having their processing of pain go haywire. Okay. Fibromyalgia is considered one type of also pain matrix malfunction, this increased sensitivity to touch and difficulty with managing balance between the anti-nociception and pro-nociception systems. We have an anti-nociceptive system. We have a system that helps downregulate pain, where I was telling you about, like from the brainstem, we send signals down the spinal cord to try to, we have our natural opiates and encalphins, endorphins that try to manage pain. And then we have a pro-nociception system that makes us make sure we attend to pain appropriately. But some people get out of whack, and their pro-nociceptive system gets too stimulated, and their anti-nociceptive doesn't work well enough, so it can't balance each other out. And so you're one piece of the key to helping to balance that system by providing normal movement and helping them experience normal movement and progressive movement and stimulation without causing excessive pain, but usually you're combining that with some behavioral therapy, some medication, that kind of stuff. There's some mechanisms that produce the actual specific mechanisms that produce some of this neuropathic pain. So your book talks about some things. One is called ectopic foci. So especially in the periphery, if you get damaged, you take a nerve and you start monkeying with it, you roll it around, you stretch it, you damage it, you irritate it, the myelin gets damaged. And you have all these little axons near each other that each have myelin. Once you start damaging myelin, you get that myelin starts to open up little areas on the nerve where you actually start to insert more ligand-gated and voltage-gated channels. And so these little things are called, so those areas of the nerve that are exposed are more likely to just cause a spontaneous action potential to occur and cause pain when you just maybe like with carpal tunnel. So carpal tunnel, you have the nerve, median nerve running through there. It starts getting damaged and roughed up. And you start getting these exposed areas on the axon that start to then get these, extra sodium channels inserted in them. And so now just moving my wrist, instead of, the peripheral receptors aren't getting stimulated out here, but the nerve itself is getting stimulated at the actual axon. It doesn't even require the receptor to get stimulated, but the axon can start to depolarize just from getting rubbed on or irritated or moved through the carpal tunnel, that kind of stuff. Those are ectopic foci. They're ectopic, they're foci, there's areas of focus away from the normal area, and they're just on the axon itself, okay? Then there's ephaptic transmission, and usually ephaptic transmission and ectopic foci can occur at the same time. So when you have damage to these little axons and the myelin's disrupted, and you have these ectopic foci, and you get the spontaneous firing of the nerves, but the nerves are close to each other, they tend to spread to the other nerves nearby. And so, because they also have exposed areas on their axons. So this is called crosstalk between neurons. So once one axon or two gets stimulated, it tends to spread to the other ones nearby and enhance or make the signal stronger and worse, because you've got this irritation and degradation of the myelin and the axon. This thing called central sensitization, this is where you basically, the more you use something, the stronger it gets, the connections between them. So, but you can get to the point where they're so strong that it can be a negative, okay? And then, so you strengthen these connections between the actual axons and the different orders of neurons, where you get stronger connections at the synaptic cleft, you get increased actual receptor sites, you get increased release of synaptic vesicles, you get the cells to upregulate their metabolism, to do more production. They might grow sprouts and collaterals to other axons nearby. So you're strengthening this pathway. But then it can get to the point where you get actual spontaneous activity. It gets so strong and so sensitive that any little thing can set that pathway and send a pain signal or response, okay? Sometimes, the reason our bodies do that is protective in nature. If I've got chronic problems with my ankle that I've sprained 40 times, it wants to protect it. And so I'm going to sensitize that area of my body so that I don't hurt it again for the 41st time. But it can get to the point where it can cause a problem where I have so much pain. Maybe I get the surgery or I put a brace on it, but I'm still getting these really abnormal or strong pain signals, even though my now limb shouldn't be hurting or I've got it protected or that kind of stuff. So these guys work together, the structural organization, central sensitization. However, structural organization can actually happen also in the periphery, okay? Central sensitization is just what's happening once it gets into the spinal cord, up into the brainstem and cerebrum. Structural organization involves both the central nervous system and can involve the peripheral nervous system, okay? This is where you actually might get crazy things happening, like A beta fibers, which are proprioceptive fibers that are coming in the same area in that dorsal root at that same level with some C fibers. You might get some crosstalk, so now just moving a limb or just blowing on it or touching it causes pain when it shouldn't, because the A beta fibers grow some collaterals over to the pain areas in that dorsal horn, where normally they shouldn't talk to the pain. They shouldn't talk to the substantia gelatinosa, but they may. They may grow, especially if you're associating pain with movement for a long time, then your A betas say, hey, maybe I should send a signal over to the pain, because every time we move, we're getting both pain and movement at the same time. And so you get this, that's one way. You get actually increases in number of channels, sodium channels. at those, even the peripheral, first order neuron kind of locations. And you may even get sensitization of the receptors. The free nerve endings might get more sensitive. So lots of things that can happen. And this all can lead to this altered, well, not, I shouldn't say that. There's the other thing is altered top-down modulation. This is normally your top-down modulation is your ability to top down from your brain and brainstem to modulate pain at the spinal cord and at the periphery, okay? This is your anti-nocioceptor system, anti-nocioception or anti-nocioception system, okay? That can be reduced. So some people just don't do a very good job of sending the right signals down to the dorsal horn to tell it to downregulate. So that they got a problem with the reticular formation or the locus coeruleus or whatever. There's different regions within your brainstem that help downregulate and in your spinal cord. And we, again, don't know why some people struggle with that. It could be a genetic disposition. Chronic pain syndrome. This is a lack of direct relationship of pain to the specific tissue damage. So this is a more general term, chronic pain. Somebody still has pain even though the initial insult is over, okay? It may be because they have reduced endorphin levels and natural opiates, so that's that altered top-down modulation. It could be due to things like reverberating circuits. So these are circuits that are set up that once you start them going, they tend to keep themselves going. That's called a reverberating circuit. And that's part of that central sensitization too. So that is that once you get it going, it tends to keep itself going. They actually grow collaterals that go back to themselves to re-stimulate themselves. So once you get the signal going, it tends to keep itself going. And then you start having, because you're in pain, you don't sleep. And because you don't sleep, you're not producing enough serotonin, which causes you to get depressed. And then because you're in pain, you're not doing normal activity. So you're not getting aerobic conditioning, you're getting weak, and you're not getting the normal benefits of movement that help modulate pain. And then you're getting abnormal movements. So now you're starting to get an antalgic gait. And that causes pain in another part of your body. Or you're not using one limb, so you're using your left arm all the time. Now you got rotator cuff on that. So you see this just cascade. And we as a physical therapist can intervene in a lot of these. So even if I can't fix the sympathetic, maintain pain, the complex regional pain syndrome, I might be able to teach them strategies to still stay functional or as active as they can that might then help with their sleep or might help them maintain their cardiovascular fitness or help them stay functional, be able to dress themselves and without causing increased problems. So, okay. Pain matrix malfunction we've mentioned already, so I'm not going to get into that, but just you can see these are all examples of pain matrix malfunction, including migraines. Sometimes they think that migraines are some dysfunction in the trigeminal-thalamocortical pathway. That trigeminal-thalamo, somewhere in that area can cause migraines, I think, is one of the reasons. This is just showing you what somebody's limb looks like with complex regional pain syndrome. So here's somebody, maybe they sprained their ankle 2 years ago, and they ended up with this complex regional pain syndrome. So you can see this swollen, red, it's shinier, usually it doesn't sweat, and it's flaky sometimes, and so this is this complex regional pain. And you barely blow on it, touch it, the patient is very protective of it and doesn't want you to do anything with it. So this is now our natural pain control systems we're going to talk about. So how do we modulate or try to dampen pain responses? Through various mechanisms at different levels in the nervous systems. This is all collectively called our anti-nocioceptive system. Level 1 occurs in the periphery. Okay, so we're starting the periphery, work our way up. Examples of how we control pain. Now this is not our own body, but taking non-narcotic analgesics. It inhibits synthesis of prostaglandins. Prostaglandins, when you destroy tissue, you release prostaglandins, and prostaglandins stimulate free nerve endings, which cause pain. And so you take, ibuprofen, whatever, non-steroidal anti-inflammatories and non-narcotics, and they will downregulate and cause inhibition. Okay? Or something like ice. If you put ice, that'll numb up the tissue. For one thing, it'll make it more numb, but it also may decrease inflammatory or metabolic activity so that you get a little less pain temporarily. Okay? So that's all this is showing. Level 2, so now we're moving up to the level 2 of how we impact pain or try to downregulate it. This occurs at the dorsal horn. This occurs at the dorsal horn when the pain signal first comes in to the back part of the spinal cord. We have inhibitory interneurons. So we actually have little interneurons in there that are inhibitory. So we can, right at the dorsal horn, downregulate or inhibit pain using these inhibitory interneurons. We can also do that. Part of this inhibitory interneuron is through this gating or counter-irritant effect. So have you ever done where you whack your thumb, you smack something, and you go, ow, and you rub on it, or you squeeze it real hard, or you do something like that? What you're doing is you're trying to bombard that same area, that same dorsal root, that same spinal nerve with lots of proprioceptive mechanical stimulation to mask the painful sensations. And what happens is that's because you do have some inhibitory interneurons. So if you dump a bunch of proprioceptive information into that back part of that spinal cord at the same time some pain is coming in, there's little inhibitory interneurons that will communicate from the proprioceptive input to the substantia gelatinosa and tell it and mask it or downregulate it or dampen it. So that's why you like rub on it or try to do that or like shake it. Ow, ow, ow. You're trying to bombard it with proprioceptive input to mask the painful stimulus. Okay. The other thing we do is when we talk about the brainstem and those levels going down to downregulate or to inhibit what's happening at the spinal cord, at the dorsal horn, it's because they're releasing basically one of these three different types or classifications of natural opiates or endorphins. So this thing we call endorphins is typically referring to a combination of what's called encalphins, dynorphin, and beta endorphins. So collectively, these are all endorphins. But those are just natural opiates. Those are neurotransmitters that are released down at the dorsal horn. So as these pain signals are coming in, they get blocked. Inhibits that signal coming in. And generally, these are because you have axons coming down from your brainstem that are going down and delivering this stuff at each of your levels of your dorsal horn throughout your, okay? This is just showing you that gating mechanism. So here's a mechanoreceptor, an A beta fiber. It's coming in the same. This is the medial division of the dorsal root. Here's the lateral division of the dorsal root. Here's the pain, C fiber coming in. But if you stimulate these guys at the same time, this mechanoreceptor, this proprioceptive neuron will often connect with an inhibitory interneuron that can cause inhibition of that signal in the substantia gelatinosa, downregulate it. And that's why they do the progressive like shoulder loading. You're trying to do this progressive loading of mechanical proprioceptive information in a regular, systematic way, frequently, to keep trying to downregulate that hyperactive response that this person might be feeling with like a complex regional pain syndrome. Level 3 is called the fast-acting. So fast-acting neuronal descending system. So this is just descending. These are axons descending from some higher level down to the dorsal horns, typically, down to the spinal cord. And they're from one of a couple areas. One is called the raphe nuclei. Don't worry about in the rostral ventral medial medulla reticular formation. Just know raphe nuclei. But it's in the medulla, in the reticular formation. And that's via the raphe spinal tract. So you have the raphe spinal. It starts in the raphe nucleus, and it goes down to the spinal cord. So these are axons that project from the raphe nucleus to the spinal cord. And they release serotonin at the dorsal horn, which in turn stimulates encalphin to be released at the dorsal horn to produce inhibitory interneuron activity. Okay? So it's this cascade of events. So the raphe nuclei, they stimulate the release of serotonin at the dorsal horn. Serotonin causes actually release of encalphins at the dorsal horn, which activate the inhibitory interneurons to inhibit pain signals coming into the dorsal horn. And what activated the raphe nuclei in the first place, it's part of the reticular formation. It got activated by one of your slow pain pathways called the spino-reticular tract. Remember one of our spinal it's going to the reticular formation, and the raphe nuclei is in the reticular formation. So the slow pain pathway eventually gets up there, tells the raphe nuclei, hey, I'm having some pain here. Why don't you go ahead and downregulate that a little bit? You know, as long as the pain experience is over, we're not having active tissue destruction. Let's send some signals down there to start turning it off, turning that pain response off. We also have the periaqueductal gray, which is another area of cell bodies that have axons that project down, and they actually stimulate the raphe nuclei. So they basically enhance the raphe nuclei's effect. And remember what pathway, slow pain pathway stimulates the periaqueductal gray? The periaqueductal gray is in the midbrain, the mesencephalon. So the spinal mesencephalic tract stimulates the periaqueductal gray to stimulate the raphe nuclei, or enhance the raphe nuclei stimulation to just kind of help then strengthen its signals to down to the spinal cord. Then we also have a structure called the locus coeruleus. Locus coeruleus is in the pons primarily, and it's also part of the reticular formation. Just like the raphe nuclei is also part of the reticular formation, but it's in the medulla. The locus coeruleus is up in the pons. It's also part of that reticular formation. And it activates or sends its signal down a tract called the cerebriospinal tract. So there's a raphe spinal tract and there's a cerebriospinal tract. So it's cerebrio, starts in the locus coeruleus, and goes down to the spinal cord to do the similar function to cause inhibition. But it does it a little differently. It releases norepinephrine directly on the primary afferent, which norepinephrine then suppresses the release of substance P. But remember, substance P is what the slow pain pathway uses at that dorsal horn in the substantia gelatinosa. That's the neurotransmitter. So this helps to decrease the release of substance P at that particular location. It's in the reticular formation. So it's activated by the spinal reticular tract. That slow pain pathway eventually causes. So all this is happening at the same time. Okay, this is all redundant systems that help to modulate pain, and the stronger the stimulus to them, the stronger they're going to try to then inhibit pain, antinociception. So that's all that's just showing here is these are your different spinal reticular, spinal mesencephalic tracts that go and activate these different regions in your brainstem to send signals down to the dorsal horn. Don't need to get caught up in the details of that. Level 4, this is interesting. This is the hormonal system. So we have a hormonal system that can be involved in pain regulation and downregulation of pain. It involves the periventricular gray matter. We talked about the PAG. The periaqueductal gray is a gray matter around the cerebral aqueduct. There's a thing called the periventricular gray, which is a group of cell bodies that are near the third ventricle. So, but don't worry, don't get caught up in that. It's in the hypothalamus. The periventricular gray is a part of the hypothalamus, which is the hypothalamus is on each side of the third ventricle. It also involves the pituitary gland and the adrenal medulla, signaling the adrenal medulla sitting on top of your kidneys to release some things. So what happens is it causes release of beta endorphins by the pituitary. Beta endorphins then circulate in our bloodstream, and beta endorphins are inhibitory to pain. Okay, so it takes a little longer for this to get going. This is part of the more slow activating pathways or ways of managing pain. We just talked about the fast activating ones. This is more slow because it's hormonal. It has to get in your bloodstream. It takes longer to get to its location, but it lasts longer too. It stays in your bloodstream. The effects are a little longer lasting. You also will release an encalfin-like substance, it's not truly encalfin, from the adrenal medulla. The adrenal medulla, it goes into your bloodstream, same thing. It circulates around to those nerves and helps to downregulate them. It's delayed effect, but you can get it to last for hours. So that's the hormonal system called level 4. Last one, level 5, cerebrum, cortical level, mind over matter. This is where mind and body, and where you do have definitely some ability to moderate or respond inappropriately to pain based on your belief systems, your how you were raised in response to how you're supposed to respond to pain and those kind of things. That's the cortical level. So this is how placebo works. You know, I mean, you can, and I had a clinician I worked with for years who was the master of the placebo effect. It took me a while to figure. He got phenomenal results, and he did the most hocus pocus bullshit I'd ever seen with patients. But he actually believed it. He believed what he was doing. He was like the healer, you know, like wave my hand over you, do your chakras, energy levels, and all that stuff. He believed it, and he would go into the patient. He would say, I'm going to do this technique. You will be better. You'll be 77% better in 43 hours. I mean, he would literally set the condition up to say, you're going to be this percent better by this particular date, time, whatever. And then he would do whatever hocus pocus magical technique. And my God, 90% of the time, the patients were better, 77% at 3 days, because he told them, and he believed it. And just his personality, his own belief, the way he touched the patient, the way he looked at him in the eye, he got phenomenal results through the placebo effect. Now, is that wrong? Take money to do placebo effect if the patient got actually better? I don't know. But could I also do it a different way and teach the patient about pain physiology and say, you don't need me to do this because you have the ability to control your own pain. Because no matter what, if you've had pain for a while, a significant amount of it's going to be something you have some conscious control over. So I'm going to teach you strategies. I'm going to teach you meditation. I'm going to teach you about breath and about that. I'm going to teach you about the benefits of just movement, physical activity, and you are in control. You don't need to come see me every 3 months or anytime you have a problem and pay me all the time. Now, there are people though that's how they make their living, and they get results. But I don't know that's, to me, it's not ethical, because I know that there's data to say we can teach patients to do it for themselves. I'd rather teach them to do that. So, but on the so that's placebo, or if you distract somebody from their pain, or if somebody is really fearful, their pain levels go up. So you have to be attentive to that, to your patient. If they're really fearful and you're going to manipulate their neck or something, you got to get them to relax. Or you distract them, and then you manipulate their neck. Or you use relaxation and the music and the lighting in the room, all those to your advantage to get down regulation of pain at the cortical level. So it's powerful. Look at David Blaine. Have you guys seen David Blaine? The stuff he does, the stuff he puts his body through as far as pain, and getting put in an ice block, or sticking things through. You see, he's just sticking things through his hand all the way through, real stuff, because he's mastered the cortical level modulation of pain. So, any questions on pain, somatosensation, clinical perspectives? So, what we're going to do now is go to the lab, and we'll do some quick sensory testing stuff, and then we will. Then I'll go ahead and do the clicker quiz with the actual multiple choice questions, talk to you about the exam, and then I might do one case study at the end if people want to stick around and do case study or something like that. So. All right, see you in a few minutes.